Okay, good evening everyone to OrthoTV online in association with Pulse Pharma, the makers of Bakbone, Deksel and Kneeflex. To introduce the topic today and the faculty, I'd like to invite Ms. Pompa Ghosh for further question. Over to you, Ms. Pompa.
Thank you, Doctor. Thank you, Dr. Shyam. Good evening, ladies and gentlemen. Today we are going to have a very interesting discussion on osteoporosis and the relevance of vitamin D, which will be presented by Dr. Ram Chaddha, sir, and also equally interesting topic on the fragility, that is osteoporotic fractures, and the relevance of FRAX, which will be presented by Dr. Vijay Kakatkar, sir. Before I hand over the session to Dr. Ram Chaddha, sir, let me, give a brief introduction to both these eminent personalities. Allow me to share my screen. Is my screen visible?
Yes.
Yes.
Okay, this is the topic for today's discussion, as I just mentioned. Now, I'll be Dr. Ram Chaddha, sir, of course. He doesn't need any introduction. He's a consultant orthopedic spine surgeon at Leelavati, Jaslok and Global Hospitals at Mumbai. Sir completed his MS in the year 1989 and, of course, his fellowships in the France, Germany, Switzerland, and the United States of America. Sir has also been an ex-professor and HOD of AJ Somaya Medical College and Hospital, and also the pioneer of MICOS, that is the minimal invasive cosmetic spine surgery. Also, sir has numerous scientific papers, editorials, podium presentations, and orations to his credit. That was about Dr. Ram Chaddha, sir. Now, let me introduce a very senior orthopedician, Dr. Vijay Kakatkar, sir. Dr. Kakatkar is an orthopedist with an experience of 45 years, is almost half a decade in this field. Sir practices at Kakatkar Hospital at Nasik, which is at Indira Nagar. Sir is also a consultant orthopedist at Apollo, Suyash, Sayadri, and Ashoka Medicare Hospitals at Nasik. And sir has completed his MS in the year 1977. Now, before I hand it over, I would like to talk just few slides about my organization, which is Pulse Pharmaceuticals. Ladies and gentlemen, Pulse Pharmaceuticals has recently completed 25 years of progression. Pulse stands for Passion for Innovation and Compassion for People. Pulse is a patient-centric, innovation-driven integrated pharmaceutical company with a growth model, 25 years of active presence. We have a world-class R&D and manufacturing infrastructure, a strong leadership and operational teams across all the business functions, and leading space in nanopharmaceuticals, of which our vitamin D is a shining example, that is Deksel, and drug delivery research, and strong presence in medical nutrition through Pulse NutriScience, foraying into immunocell therapeutics by developing novel CAR technologies. These are few of the, places where I would just, give a one-liner on. We have a PARC, that is Pulse Advanced Research Center at Hyderabad, Pulse NutriScience R&D and Manufacturing Facility at Genome Valley, Hyderabad. Also at ICICI Knowledge Park, we also have a manufacturing facility at Roorkee and also at Hyderabad. Our business philosophy, of course, centers around customers providing high quality products and services by using advanced technologies, and a few of the awards. I would like to conclude this with few of the awards, that is Udyog Bharat Award at 2006, Hall of Fame Award 2010, National Award for Quality Excellence 2011, and the SMA Forum Award in association with NDTV in 2018. Thank you, ladies and gentlemen, for listening to me. And now, with due respects, I would hand over the session to Dr. Ram Chaddha, sir. Over to you, Dr. Sir.
Thank you very much, Pompaji. Good evening, everybody. At the outset, may I acknowledge the presence of Dr. Vijay Kakatkar, a very senior orthopedic surgeon, a mentor and a role model to most of us from the western part of India and other parts of the country. Welcome, sir. It's a privilege to be speaking here with you and sharing the podium with you. May I take the opportunity of setting the ball rolling? I would be speaking about osteoporosis in general, the role of vitamin D and the way that an orthopedic spine surgeon looks at it today. We are here today growing older, but I would rather like to use the word aging gracefully. And the difference between growing old and aging gracefully is that we should not just add years to life, but life to years. Unfortunately, a trivial fall at times may give an osteoporotic fracture. And there are various causes which have been sort of pointed out as to why we get a fracture, which actually suddenly comes as an obstacle to quality of life. Calcium, vitamin D3, B1, B6, B12, we blame each, if not all of them. We, however, overlook osteoporosis. We always believed it was a silent disease, but today we believe it's not a silent disease, but a bone-shattering thunderstorm. We in India are fighting against it with our backs to the wall. Orthopedic surgeons have always believed that we should only look at surgeries, and osteoporosis is just a medical disease. Why should we be bothered about it? Ladies and gentlemen, we have to be bothered. It's our patients, it's our quality of surgery, it's their quality of life, and it's our quality of life, which is at stake if we disregard the quality of bone. Hence, please do understand that always have your antennae up when you're dealing with people who have fractures more often than they ought to, at an age where they don't have to, or even after a trivial fall. Let's look at a situation which happens with our parents or our grandparents and may happen with us soon. We have people who've had this thoracolumbar junctional pain, a trivial fall more than a month back, now losing balance for a day, weakness with some challenge maybe early to the bladder or bowel, sensations, reflexes may be grossly normal, and she may just not share unless asked whether she's having some loss of control over her bladder. Uncommon, but true. They otherwise are fit, there's no weight loss, there's no fever. The X-ray looks something like this 40 days back. What do we do next? Continue conservative care? Get another X-ray done? If so, what? Do blood work and bone density and MRI or CT? Well, each individual is different. Yes, we need to do X-rays in sitting and supine. And lo behold, at 40 days post-injury, same lady, 71 years of age, when she sits, there's an almost concertina collapse of the thoracolumbar junctional fracture. This tells us that there is not just an instability, pain, and threat to neurology. DEXA in this situation, difficult, but if available, ideal. I always do vitamin D3, B12, calcium, creatinine, parathormone. I also rule out multiple myeloma, do an ESR and a CRP. I do kappa-lambda light chain ratio. And if possible, within limits of pain, it's 40 days back, I would love to do a DEXA and quantify, document that she has a minus 3.2 T-score on DEXA in the lumbar spine AP. Well, threat of neurology, yes, we would do an MRI, screen the entire spine so that we don't get surprised by something which was unexpected. Yes, we have proven that not just there is a cause of concern, but there's an incidental cause of concern in the mid or upper thoracic region as well, besides the hemangioma, which is noted elsewhere. What do we do now? Conservative therapy or surgery? How can this be managed? Many would say just continue medical therapy. Others would say augment medical therapy and then do surgery. While the orthopedic surgeon, spine surgeon in me would say, chalo, operation karte hain, we'll look at everything else later. I'm giving you the options. You could do cement augmentation. You could do cement augmentation with minimally invasive stabilization. In the presence of neurology, you could do a decompression with stabilization. And rarely, not in this patient, you may have to do an anterior reconstruction. This is what this lady underwent. Look at the fracture up there, which was left without any augmentation, but this was minimally augmented and a long posterior construct over the thoracolumbar junction. What's the message? Vertebral compression fractures less than 6 weeks subacute. I would do just cement augmentation, sometimes a kyphoplasty, but usually a vertebroplasty. Early neurology with a dynamic instability, I would do an indirect decompression by a posterior stabilization. If it's a much denser neurology needing decompression, I would probably shorten posteriorly rather than augment and build up anteriorly, besides just a little bit of cement in front. But rarely, if it's an old and a fixed sort of a deformity, then I would probably need to do a back and front job and customized bracing with medical management. Why do I put medical management in capital? Because that is the most important. What are the learning points? Most fractures will heal with collapse and deformity. That's what was at the time of trauma. That's what was at the end of about 2 months. However, many may have non-union, pseudoarthrosis, instability, pain, neurodeficits, and loss of function. Those which don't heal are the ones that need surgery. And this is the way forward, provided we have a very robust medical management to support it. What's the medical management? Regular calcium, D3, B12. HRT is what we used to call it earlier, hormone replacement therapy. Now they call it menopause replacement or an MRT or an MST. SERMs, bisphosphonates, teriparatide, and denosumab. As per the indication, it's an integral part of treatment. What's the role of calcium and vitamin D3 in bone health? Well, we all seem to have calcium deficiency. We take less of it. We are vitamin D deficient, hence there's also less. There's insufficiency or failure of PTH in many people. A lot of patients have chronic kidney failure. They have low magnesium levels, or they have high phytate. That's the type of diet we eat. Vitamin D deficiency is common and is a global health problem, even in tropical places like India. 94% of urban Indians are vitamin D deficient, while only 70% are vitamin D deficient among the rural population. Still, that 70% is also very, very significant. It's not because of lack of sunshine. It's a combination of multiple reasons: the ethnicity, the quality of our skin, the exposure times, the amount of clothing that we wear, all these things put together. What's the ideal level of vitamin D? More than 30 nanograms per ml. Acceptable is 29 to 29. Insufficient is 10 to 19, and deficient is less than 10. Something that we, over the last few years, have realized that this is just passing marks, 30 nanogram per ml. For good quality of life, we actually need much higher than that. 30 to 100 is a very large window. In school, 35 out of 100 was passing marks. But then there was a huge difference between a guy who got 35 and somebody who got 85 or 90. Quality of life is dependent on vitamin D. And vitamin D at times does behave like a hormone, though it's not so. And it is day by day getting more and more important. Regardless of the deficiency of vitamin D or the vitamin D sufficiency, most people worldwide are suboptimal as far as vitamin D levels are concerned. The NOF has recommended an upper limit of vitamin D intake for an adult population at about 2000 IU per day. Recent studies indicate that higher intake of vitamin D is still safe and is required to maintain an optimal 25 hydroxy level. So where are we coming to? We are coming to say that even more than 60,000 IU per month is necessary. 30,000 IU per day means about 60,000 IU per month. is still less than what we really need. We probably need much more. The Endocrine Society recommends 1,500 to 2,000 IU of vitamin D for adults and 1,000 for infants and children. Well, all these say this is just to get the baseline, but for quality of life, we need much, much more. What's the role of B? Well, it's equally important and is a major co-prescription. At times, B vitamins and hyperhomocystinemia do occur, and these may also have independent risks as far as the bone quality and bone health is concerned. So where do I lead you all? Well, I recommend at the time that a woman is going to have a peak bone mass, that's the time that you initiate calcium and vitamin D3 therapy. Post-menopausal, I always insist on a DEXA. I would initiate menopause replacement therapy or selective estrogen replacement like SERMs. I would have my endocrinologist and gynecologist take care of that part because I am not proficient enough to do the same. When I have treatment naive patients, but who are not severely osteoporotic, I initiate bisphosphonates, oral or injectable. Oral is usually weekly, injectable is once a year. Oral is alendronate or risidronate, injectable is zoledronic acid. At times, after 2 years or later, I may swap to the monoclonal antibody, which is denosumab. And bisphosphonates, if given for 4 years, I recommend at 4 to 5 years a treatment holiday. Denosumab can be given 60 milligrams subcut up to 10 years. And severe osteoporosis, I love to use injectable teriparatide, daily 20 micrograms for 2 years. Yes, now there is a lot of debate whether we build up bone with teriparatide first and then give denosumab, or we use denosumab first and then give teriparatide. The pendulum seems to be swinging towards building up good quality bone first. And hence, a lot of people do use teriparatide, but we need to check that your creat is fine, that your PTH is not too high, and your vitamin D is not too low, and there is no past history of malignancy in such patients. As far as denosumab, calcium and creat, well, calcium needs to be fine. A little challenge on the kidney function, we can still use denosumab. Alendronate is what I use as a bisphosphonate, as I said, 70 milligrams per week, or risidronate 35 per week. Zoledronic acid, 5 milligrams IV up to 4 years. Denosumab, as I mentioned, 60 milligrams subcut up to 10 years. Teriparatide, 20 micrograms subcut daily for 2 years. Besides this, it's extremely important that you do regular exercise, don't put on too much body weight, stop smoking, and eat and drink healthy. Expose yourself to sunlight. Peak bone mass is around 25 years, decreases after 35. Calcium and vitamin D are major contributors. In India, with low calcium and vitamin D intake, daily intake of 1,000 to 2,000 IU of vitamin D3, along with 1,000 to 1,200 milligrams of calcium is recommended. High daily intake of vitamin D is safe and important, not only for bone health, but for overall health. As far as patient adherence is concerned, I find it much easier to initiate a weekly preparation rather than a daily preparation, because somehow people tend to forget. But then if there is somebody who's taking a bunch of pills every day, there's no objection to taking it daily as well. Vitamin B is also to be added and should also rule out hyperhomocystinemia. So finally, it's your choice. You want good bones and good quality life, or you want to have weak, fragile bones and fractures. So think twice. We are all aging. We need to age gracefully and add life to years rather than just years to life. Thank you all for a very, very patient hearing. It's been a pleasure giving just an introductory talk today. Before I would call upon my teacher, my mentor, a person who has extreme passion for what he's doing, and hence he's doing it even at this age, at this time on a Saturday evening, Dr. Kakatkar, to share his experience. A man who has a passion and a purpose, a man who has compassion for his colleagues, and I'm really touched by all that he does, and surely a person who's dispassionate about designations. Over to you, sir. It's all yours. Thank you so much.
Thank you, Ram. I think it was an excellent talk, extemporary almost, because I know that you were totally caught unguarded and you were asked to speak initially without slides, and suddenly you had to give a talk with the slides. It was an excellent talk, and thank you very much for all what you have said about me. Thank you. Are you able to see my screen?
Yes, sir. Sir, your screen is visible. Only
Yeah.
full screen if you.
Yeah, I'll make it full screen.
Sure, sir.
Yeah. So thank you, Pulse Pharma, and thank you, Ram. Thank you, Ashok from the OrthoTV. I think this topic of osteoporosis is one of the real burning topic today, because as Ram has already said, we are having a definite longevity increase in the last 3-4 decades. And as the aging population is increasing, I think the problem of osteoporosis is going to be a major problem for all the specialties, including our specialty as orthopedic surgeons. As we know, by definition, osteoporosis is a systemic skeletal disease characterized by a low bone mass and microarchitectural deterioration of bone tissue, with a consequent increase in bone fragility. The disease often does not become clinically apparent until a fracture occurs, so it is called as a silent killer or silent disease. As Ram has already said, if you see the graph of how you gain the bone density from your birth to the age of 25 years is the age of attainment of peak bone mass, then you maintain that bone mass till the age of 40. And after the age of 40, in males and females at a little different speed, especially after the menopause, the females have a rapid fall in the bone density. But this is the graph which gives us an idea about how everyone starts losing his bone mass after the age of 40. I'm going to first talk about some very important point, which is a FRAX score. As Ram has already said, the prevalence of osteoporosis in postmenopausal women is about 35 to 50%, a very alarming figure. And the mortality associated with hip fractures is about 20%. It was very nicely said in our orthopedic books that a man is born through pelvis and leaves this world through the hip. So that's the kind of picture scenario after the hip fractures in the elderly people. Osteoporosis continues to be underdiagnosed in the primary care setting. One of the reasons for this is attributed to the poor availability of DEXA scan in especially rural areas. But I would go ahead and say that even in the urban areas, it's something which is not very easily accessible to the patients. And more than 100 million postmenopausal women are there in India today. And out of this, more than 2/3 of them reside in the rural areas. So you can imagine how many people do not have access to the DEXA. The Fracture Risk Assessment Tool, or FRAX, is an online web-based tool that takes into account multiple factors that help in predicting the 10-year risk for developing hip or major osteoporotic fractures. And this is very important because you want to predict whether somebody is going to have multiple fractures in the next 10 years. The advantages of using the FRAX tool are that it is inexpensive because it is available online, and it is easily available and does not need a DEXA scan as one of the prerequisites. Besides low bone mineral density, there are several other causes which predispose to fractures, like increased propensity to falls, which happens in elderly people, lifestyle factors including smoking, alcohol consumption, and systemic disorders like diabetes and medications, especially the steroids. So, looking at this aging population, WHO collaborating center in Sheffield analyzed different potential risk factors from 60,000 subjects belonging to the following cohorts: like Rotterdam study in Netherlands, European vertebral osteoporosis study from 13 centers in Europe, Canadian multi-center osteoporosis study, then from Rochester, USA, Sheffield, England, then this study from Australia, and 2 studies from France, and then from Finland and Hiroshima, Japan, and from Gothenburg, Sweden. Number of these centers, they collected the data, and on the basis of that, actually they have formulated a FRAX score, which takes into consideration the following factors: the age, sex, bone mineral density, that is one of the parts is BMD, then BMI, prior fragility fracture, use of any oral glucocorticoids, any history of any parents having a fracture basically in the hip, then smoking, alcohol, and rheumatoid arthritis. Let's consider about these factors one by one. As we know, the loss of bone mass increases as you age. And we have already said that in females, because of the hormonal changes taking place at menopause, the females are at more risk of osteoporosis than males. You're having low weight and being frail can raise your risk for osteoporosis. Similarly, having obesity also can increase the risk of osteoporosis. So both extremes are bad. Your height, your previous fracture, parent fracture hip, and current stage of smoking, glucocorticoids, rheumatoid arthritis, and autoimmune disease, which is definitely having a higher risk of osteoporosis. Then secondary osteoporosis because of the pre-existing conditions like type 1 diabetes, hyperthyroidism, chronic liver disease, premature menopause, and so many other conditions. Then 3 or more alcoholic drinks per day and low BMD. This is a kind of form that you get online to calculate your FRAX score. And all these factors which we have already discussed, you have to fill up. You have to start from your country, whether you are a Caucasian by race or whether you are from the other parts of the world. Because as it has been rightly said, the ethnicity also makes difference in the bone density. So you have to fill up the country, then your name and all the other details into this form. If you have done a BMD, then you have to fill up the data of your BMD, and then you have to put the cursor on calculate, and it gives you the idea about your FRAX score. So this is an excellent tool which is available online free, but there are some limitations of the FRAX tool. This does not encompass all the important factors that may predict fracture risk in a given individual, like physical activity, vitamin D deficiency, about which Dr. Ram has already talked in detail, likelihood of fall assessment because of loss of balance, then bone turnover markers like alkaline phosphatase and parathormone levels, and rate of bone loss in sequential bone BMDs. But there are certain advantages of FRAX tool, that it considers associated risk factors apart from DEXA scan, and this can be used even if DEXA is not available. It is a very cost effective, can be used in rural setting and easily available online. The most important thing is what is the clinical application of this FRAX. The current National Osteoporosis Foundation gives guidelines in treating the patients with FRAX score for 10-year risk scores. If you have a score of more than 3 or equal to 3 for hip fracture, or more than 20 or equal to 20 for major osteoporotic fractures, it means you need specific treatment for osteoporosis. So to summarize, DEXA is still the gold standard, but the availability and cost becomes a barrier, especially in rural areas. FRAX score is independent of BMD values, easily available online, free of cost. It is rapidly becoming the most widely used fracture risk assessment tool world over. Additional risk factors such as frequent falls not represented in FRAX score warrant individual clinical judgment. So you just can't rely only on the FRAX score. I think your clinical assessment of a patient is also extremely important. FRAX has the potential to demystify fracture risk assessment in primary care for patients with low bone density, directing clinical fracture prevention strategies to those who can benefit the most. That is mainly for the rural population. So I think this is all about the FRAX score, because this is something which is coming new and many people are not aware about exactly what is FRAX score. So I think I tried to summarize about the FRAX score in detail. Now, the second part of my talk is about the osteoporotic fractures. As we are aware, there are cancellous and cortical bones in our body, and there are changes taking place in osteoporosis in both the types. The cortical bones, the cortex becomes thin, the medullary canal becomes wide. There is a very poor holding capacity into the cortex of any implant like screws. And whenever there is a fracture, you get severe comminution because of the porotic bone. So this is a comparison between a normal versus osteoporotic bone. The cancellous bone changes are much more pronounced, and there is a reduction in the number of trabeculae. The trabeculae become more thin and sparse, and many trabeculae are lost. So this is a diagrammatic representation how the spongy or the cancellous bone show changes because of osteoporosis. And in this context, I will definitely like to mention about the Singh's index, which in today's world, it doesn't become very relevant because it is because of the facility of DEXA scan. But the time that it was invented by one of the Indian surgeons, Professor Maini, this was one of the indicators which gave you idea from the X-ray of a hip that whether the patient is developing osteoporosis by the number of trabeculae and how they disappear. So I think we must remember about this contribution by our senior Indian surgeon, and we must pay respect for that. If we see the pathogenesis of osteoporotic fractures, we can see in a diagram like this that there is a low peak bone mass, postmenopausal bone loss, age-related bone loss, other risk factors all lead to low bone mass. And poor bone quality and non-skeletal factors like propensity to fall put together along with low bone mass leads to osteoporotic fractures. The commonest bones to get involved are vertebral fractures, about which I think Ram has talked in detail. Then hip fractures is the second one, which is commonest. And the third is lower end radius, and the fourth is proximal humerus fractures. These fractures are the markers for the future fracture risk, and they may occur with even day-to-day activities or with very trivial form. The signs and symptoms that we see there in the vertebral fractures, many a times, they go totally undetected, and the patients just complain of back pain and increasing kyphotic deformity in the spine. And the hip and lower end radius fractures can happen with very trivial form. In the clinical risk factors, you must know about the loss of height, loss of low body weight, advancing age, late age at menarche, the menopausal time and the time since menopause, and the additional factors like smoking, intake of dietary calcium, alcohol intake, different medications, especially the steroids, presence of any inflammatory diseases like rheumatoid, and the presence of prior fragility fractures. The physical examination findings suggest that there is an impaired ambulation, there is a muscle weakness, impaired balance, and number of times reduced vision, which makes them prone for frequent falls. And in the signs, you see there is a loss of height because of the kyphosis. There are deformities in the chest, and the rib pelvic overlap increases. You have to see for these two simple things, that is wall occiput distance. As the kyphus increases, the distance from the wall to the occiput goes on increasing, which indicates the propensity to the vertebral fractures and increasing kyphus. And the second criteria is the distance between the rib cage and the pelvis, which goes on reducing. And if it is reducing, that again indicates the collapse of the vertebrae. As far as the surgical management of osteoporotic fractures is concerned, I think we have to follow some important principles. One should try and use load-sharing implants rather than load-bearing implants like plates, and try to do biological fixation. If there is a porotic fracture with comminution, then you can think in terms of impaction or compression to get better contact. If you have to put any implant, then try to give a wide buttressing, that is long nail or long plate and long splintage. And as and when required, you should do augmentation, like in spine, Dr. Ram Chaddha has shown putting in a cement. Or in cases where it is possible, you can think of replacement. So this is a load-sharing implant in a trochanteric fracture. If you do a biological fixation because of the less disturbance to the soft tissues and vascularity, like MIPO or LIS, or if you're doing a wide buttressing, then in epiphyseal or metaphyseal fractures, you can do wide buttressing like distal radius, distal femur, or proximal tibia. You can do augmentation by non-invasive or invasive techniques like electromagnetic stimulation or low pulse ultrasound, or in invasive techniques like putting bone grafts or bone substitutes or bone cement, or injecting the platelets or bone marrow or bone morphogenic proteins. This is an example of Chron-OS inject, which was available some time back. Now they have withdrawn it from the synthase. And this was a patient who was an osteoporotic lady, had a fracture lateral condyle, and after elevation there was a void created which was filled up with Chron-OS inject. It used to consolidate, but it was a completely absorbable substitute, and this fracture was supported with 2 cancellous screws. You can think of replacement in femoral neck fractures or selected intertrochanteric fractures, as our beloved teacher, Dr. N.S. Lard, calls it as a coxofemoral bypass, and proximal humerus fractures. There are different implants that you can use. If you have to use plates, then you should use preferably locking plates. For comminution, shorten the bone and achieve optimal cortical contact. You can do a biological plating without disturbing the fracture site. You can use longer plates with less density of screws, and you can do augmentation with cement if it is required. The locking compression plate, as we all know, has got the screws having hold in both the bone and the plate. So the chances of loosening of the screws in the porotic bone are automatically reduced. And because it's a implant which has got fixed angle fixation, so it is called as an angle stable fixation. The interlocking nails is the ideal choice for all the diaphyseal fractures because it's a load sharing and biological fixation. But one should take precautions of doing minimum or no reaming, use appropriate nail according to the shape of the bone, and you should take a proper entry point depending on the manufacturer's recommendation, and avoid nailing in distal or the 2 proximal fractures. The common fractures that we see, I think the commonest one, as Dr. Ram has already pointed out, is the vertebral fractures. And he has, I think, given enough information about the kind of procedures which are done. This is a vertebroplasty or kyphoplasty. And you can see this is an example, multiple level vertebroplasty done. And this is again a 75-year-old male patient, compression fracture which had gone almost into non-union. So we had to do a vertebroplasty. There was no neuro deficit, so that was enough. Another 85-year-old female patient, and the vertebroplasty done. And in some patients where there is increasing kyphus with neuro deficit, as Dr. Ram has already shown, we can do a long segment fixation with pedicular screws and get the correction. And this is a 5-year follow-up where we can see that the deformity hasn't increased, even though the patient has very porotic bones. Then let's see some cases of proximal femur. This is a 75-year-old gentleman who had one-sided fracture IT, which was fixed, and now he developed fracture on the opposite side. As we say that 10 years fracture risk is very high in these patients. So this was again fixed with DHS, and we have done augmentation with chronoase granules into this. And you can see the granules put over here so as to do the augmentation. This was a post-polio limb in a 65-year-old gentleman. He had a fracture which was fixed outside by one surgeon and then landed up with infection. And he came to me in a non-union situation. And the bones were very porotic, basically because of polio as well as because of the long-standing immobility and infection. So after control of infection, this was fixed with a PFN and bone grafting was done from iliac crest. And this is a 2-year follow-up. You can see an excellent union, improvement in the quality of bone by using teriparatide in this patient. And this is one of the drugs, I think, which has really come to the help of orthopedic surgeons for these difficult situations. And this is at the end of 2 years after removal of implant. You can see the improvement in the quality of cortex. This is another 68-year female with IT with a subtroch extension, and you can see a intramedullary nail PFN being used for this. Here, because there was a combination, in addition to the intramedullary nail, we have done augmentation with a tension band wire. So you have to keep in mind this particular augmentation principle. This is a 67-year obese diabetic fellow. He had undergone a hemiarthroplasty by some surgeon few years back, which had loosened out, and he was unable to walk properly, because of which he had a tendency to have falls, and he landed up with his fracture on the opposite side, for which he came to me. We did a bipolar uncemented hip on this, on the left side, but then his right side was still bothering him, and we had to convert it into a cemented total hip replacement. This is another 80-year-old female who landed up with cutout of the implant because of the osteoporotic bone. And this was again operated by a colleague outside, and we had to convert it into a long stem total hip replacement to tide over the situation. Some cases of distal femur. This was a 69-year-old lady having rheumatoid. She had very porotic bones around the knee, and she had undergone a total knee replacement and fractured patella after that. And now she landed up with this. So we had to do a periprosthetic plate fixation for this. Again, we have to put this lady on teriparatide, and this is 2 months follow-up. This was her function at the end of 2 months, and at the end of 18 months, you can see an excellent union and good function in this patient. This is another 60-year comminuted fracture of the lower end of the femur. You can see multiple pieces. So we had to augment it by putting a fibular graft plus the iliac crest graft and a long plate with locking plate. And this is a 5 months follow. You can see that the bone has started healing. The proximal humerus is another very peculiar bone for very porotic area and very prone for fractures with a very trivial fall. This is a 62-year female. She had a 3-part fracture. By deltopectoral approach, we had to fix it. And you can see that we have put a fibula inside so as to support the head which was falling in external rotation. And at the end of 2 years, this is her function. Another fracture, 4-part fracture of the proximal humerus with very porotic bones, and we had to convert it into a hemiarthroplasty. Another 68-year-old female, and this was a non-union of the humerus, 5 months old injury, and you can see the amount of osteoporosis in the head as well as into the shaft, but because the head was viable, so we had to think of reconstruction. Again, we have done a fibula plus iliac crest graft, and this is 4 months follow-up. Thanks to teriparatide and vitamin D and all the supportive measures, and this is the function at the end of 4 months. The last bone is distal radius. You can see this is a 64-year male patient. After a trivial fall, the amount of collapse of the lower end radius and a crack fracture into the ulna, and we had to do the fixation with a plate for the radius and stabilize the inferior radial nerve joint as an additional augmentation with a K wire and nail into the ulna. And this is the function at the end of 2 months of this person. Another distal radius in a female 72 years. You can see again the collapse taking place in spite of having a very trivial injury, and we had to fix it with locking plate for the lower end of the radius. Friends, we have talked all about treating these fractures, but I think looking at the aging population, it is very important to prevent the fractures, prevent the falls, for which the correct visual, one should correct the visual and the hearing impairment in the elderly population, which is many times neglected by the younger generation. Optimize the medications. One should put bathroom grab bars and non-skid mats in the bathrooms. Avoid throw rugs and slippery mats into the rooms. Keep the electrical and telephone cords away from the walking areas of the elderly people. Reduce the clutter from the walking areas. It is very useful to put night lamps in the bedrooms and bathrooms because many a times while going to the bathroom, when there is no enough light, these patients are very prone for falls. It is better to put handrails on steps and stairs. If needed, one should advocate walking aids to these people. And last but not the least, exercise for strength and balance is extremely important. The osteoporosis can be prevented and corrected partly by proper exercise program. So I think one should insist on doing exercises irrespective of the age of a patient. So I think if we follow this, then we can at least minimize the chances of osteoporotic fractures. Some hip protectors like this, which were marketed, they do have some role, but they are really not absolutely preventing the fractures if one gets a fall. So the take-home message is osteoporosis is a silent killer. The consequences of the fractures in these bones are very disabling. So awareness about it and the treatment with proper medication, which is very important, as Ram has already stressed very emphatically on medication. And if required, surgery in time can prevent this particular disability. I think I thank you very much for your patient listening. And I have tried to cover both the topics to the best of the abilities that I have and the material that I had with me. Thank you. And I thank Ram and the Pulse Pharma again for giving this opportunity to share some of my views on this topic. Thank you.
Thank you, Kakatkar sir. Thank you, Chaddha sir, for the wonderful presentations. Can I share a few questions which were there? Most of the questions you both have, answered in your presentations. But one question is, everybody would like to know is what doses of vitamin D would you recommend in D deficient patients? That is one thing. And also your views on importance of vitamin D supplementation on a daily basis, sir. Any one of you, sir, or one by one, anyone, sir.
Well, I think your first question about the vitamin D supplementation, I think I routinely do the levels of vitamin D in the patients, and depending on how much is the deficiency, I decide about the dosage. If the vitamin D levels are very low, like less than 10, I prefer giving a loading dose of 6 lakh units The injectable vitamin D given in an oral form, you ask them to drink that injection after filling it up in a syringe because it's an oily preparation. And then I prefer giving 1 or 2 doses of 6 lakh units at the interval of 1 week or 10 days, depending on the deficiency level, and then maintain it at weekly intervals with 60,000 units till we achieve at least the level above 50 or 60. And then, you can maintain it on 60,000 units either every 15 days or once in a month, depending on how much you have been able to achieve. As far as the second question, that is daily supplementation of vitamin D, my personal preference is to give it weekly rather than daily. And being a fat soluble vitamin, it gets stored into the body. So I think even if you don't give it every day, you can achieve and maintain the doses of vitamin D levels adequately by giving a weekly dose. Ram, I think your views on that.
Sir,
Yes,
I would concur with most that you've said. I have recently sort of started doing a few things a little bit differently. One, if I have a patient who is genuinely a non-affording patient, then yes, I would use the 6 lakh unit in a single digit vitamin D level, 5, 6. But I would use only one injectable of 6 lakhs. And then I would give weekly 60,000 IU for about 3 months. I'm talking of the single digit. However, if I have a patient who is not the affording, less affording types, but in fact, the other way around, a more apprehensive types who doesn't want to take an injection, or if I have a diabetic in whom I prefer not to use a deep intramuscular injection, or a person who's not happy taking that oily drink. Sir, I have started using 60,000 oral preparation, which is available now in a bottle form from various companies. And the one which I'm using presently is the one that we are talking of today, where I give it to them on a daily basis for 6 days. You understand what I'm 6 to 10 days. You can actually use that 60,000 on a daily or an alternate day till you can make that 60,000 into almost 3 to 6 lakhs, depending on where you are, and then adding a weekly dose. And now there is some literature available, studies done in our own country, where what they've done is they've taken this 60,000 and used 5 of them on 5 consecutive days. That means they're pushing in about 3 lakh units in 5 consecutive days, and then giving a weekly preparation. 1, the absorption is easier. 2, probably the percentage of absorption is higher. And 3, you're actually doing away with the possibility of a deep intramuscular injection giving its side effects. So this is where I am as far as the very, very low. Those between 10 to 30, there I go in with, as it is, a loading dose with the oral preparation of 60,000. That may be even 3 to 4, but followed by a weekly dose, which will be 8 to 12 weeks. And those who are then in the range of 30, 35, although my endocrinology friends accept that it's normal, a lot of people don't supplement, but I am one of those who have patients with low back pain, neck pain, and who have these, just passing marks in vitamin D. There also I use a weekly preparation for 8 weeks and then a monthly preparation of 60,000 IU for an entire year. And I repeat the vitamin D at 3 months after my initial treatment, whatever it is, and then probably repeat it 3 monthly or 6 monthly. Again, as I said, it's an expensive test, so we have to at times balance the affordability of the patient with doing the test. But am I using vitamin D more aggressively? Yes, I am. Am I using the oral form more aggressively? Yes, I am. Am I using injectable very sparingly? And do I get scared of hypervitaminosis D3? Sir, very rarely will you find anybody having hypervitaminosis with oral preparation. Sir, it is actually a story, but I have had a patient who's actually inadvertently taken vitamin D3 oral preparation for a very prolonged period of time. and still did not have hypervitaminosis D3. So it's relatively safe in that way. That's where I am as far as vitamin D3 preparations are concerned. Pompaji, does that answer your question?
Yes, sir. Yes, sir. Thank you so much for that. And sir, there is one more question. We have
before you ask the question,
yes,
one doubt I have is that in one of the meetings for the osteoporosis, with a couple of endocrinologists participating into it, they said that giving injectable vitamin D is out now. You should not give injectable vitamin D as a deep intramuscular injection, because what they have studied, that if you study the levels of vitamin D after intramuscular injection, many a times what they have seen is that the levels go up more slowly than the oral administration, because many a times this vitamin D gets absorbed into the fat around the gluteal area and gets very slowly released into the body. So many of them, they have stopped using injectable vitamin D unless there is some malabsorption syndrome or something like that. Otherwise, they recommend that you should fill up that oily solution and give it to the patient to drink. And you achieve the levels of vitamin D faster than giving an intramuscular injection. There was a program called as Osteoporosis Essential, in which I have participated twice. And the endocrinologists world over now, they are recommending that you should not give vitamin D in injectable form. So that was one of the inputs I thought I will share with you.
Sir, it's a fantastic input, and I am very happy to hear that. In fact, most endocrinologists whom I discuss with, they in fact are a big no-no to the 6 lakh. They are actually on the back foot for that. But since we have in the past inadvertently used even 3 and 6 injections, I'm talking of 20, 25 years back, probably we never did the levels then. But
That's
a
true.
single injection is something which we still use because our country, the majority, cannot actually really afford much of therapy. So, and the oral form is good, sir. So I am trying to just get you a thing that I can actually make that 6 lakhs by multiple small 60,000
I know.
taken
That's
together.
true.
I think
that's a new concept which is coming up, that instead of giving 6 lakh in one shot,
yeah.
every day you give a nano formulation of a vitamin D, like Deksel, and then you can achieve the levels within a week's time.
So subjective well-being also, I'm sure there is no objectivity, but subjective well-being is pretty high, sir. That is what
Yes, I 100% agree with you. Definitely.
There is
And many vague complaints, they disappear after administration of vitamin D.
Yes. Ma'am, any more questions?
Yes, sir. There is one more question, sir. That is, we have the global prevalence of osteoporosis at about 18%, wherein in the Indian scenario, the prevalence of osteoporosis, sir, stands at 25%. So we know that India sees, a lot more sunshine. And as both of you have touched upon, that race and nutrition also plays a role in the, levels of the D levels in our body. Your views, sir, if you can further elaborate on that, sir. Both of you, sir, one by one.
Ram.
Sir, my take on it is one that we are structurally smaller. We are conventionally more vegetarian. We are poorer eaters. We are more clothed than the Western population. We are, as I said, there are too many things going against us. Multiparas, all sorts of things happening in our country, which make us more prone. Sunlight, yes, we get more, but we wear too many clothes, and our skin doesn't allow the absorption. So we do have that. And one thing which I have always looked at, and now I believe in that more, sir, we are like we are the diabetic capital of the world, and diabetics also have poor quality bone. In fact, what I have learned over the years is that a -2 DEXA, a -2 T-score of a diabetic should actually be looked at as a -2.5 with intent to treat. So I believe that because we have huge amount of diabetics, we probably also are having a large amount of female and male osteoporotics which are coming in. So this is a sort of bizarre thoughts, but this is the way I'm looking at osteoporosis in our country, sir.
Well, one more point I like to add. I 100% agree with you. In the same program, this osteoporosis essential, there were some people from Delhi. They had conducted a study about why, in spite of sunshine, we have vitamin D deficiency in our population. And with the IIT people, the All India Institute Endocrinology team, they conducted a study of studying the levels of ultraviolet radiation reaching the surface of the earth in different areas around Delhi. And then they found that because of the levels of pollution, the ultraviolet rays reaching, they developed, the IIT people developed equipment to measure the ultraviolet rays reaching. And then they found that the levels were extremely poor. So the increasing pollution is one more additional factor which is responsible for having vitamin D deficiency in spite of having very prominent sunlight throughout most of the year in our country. I think if we are considering the urban population as having more preponderance of osteoporosis, I think that can be one of the contributing factors which was discussed during that meeting. Yes, any more questions, Pompa?
Sir, lastly, this is my own curiosity. How much of vitamin D is too much, sir? How much is too much? Because since it's coming out as a very essential part. I mean, once we have seen your presentation, sir. So that if you both could please touch upon. Yeah.
I think up to 100 people say that it's a normal range. So anything crossing 100, I think you have to take it as too much. So I have seen one or two patients in the last couple of years because of the Google knowledge, so many people have become too much crazy about taking vitamin D and they take excessive doses. I have seen some of them coming with very vague complaints of bony pains. And when we did their vitamin D levels, I have seen levels up to even 115, 120. And I think that particular toxic level was responsible for some of their skeletal complaints as per the literature reference. So up to 100, I think we can accept as higher limit of normalcy. Beyond that, I think we should take it as a abnormal level. Ram, what do you feel?
So now there is literature coming out saying that hypervitaminosis up to 150 does not cause any side effect or any symptoms, and toxicity is only reported between 150 and 300. I'm not saying that we should take that risk, but it's not as unsafe as we make it out to be. So yes, we can't go overboard, but we have to sort of look at it that it's not as unsafe at 110, 120. Yes, we should stop therapy. We should let things settle down. But the toxicity is now reported at a much higher level than what we presumed. 100 pe toxicity nahi hota. That's where we are.
Is there any antidote for hypervitaminosis D? Do you know of any such drug? Can the Pulse Pharma people throw some light on that? Do you have some antidote for hypervitaminosis D? Your research team must be knowing something.
Sir, I will definitely put this question, I mean, as an antidote, because there's so much of vitamin, D, especially post-COVID and during COVID, there is so much of, talk about this molecule. Definitely, we will And sir, another thing is because now we have seen this monkeypox, coming in. Now this couple of cases, or I think just one case reported in Kerala. And any role vitamin D, I mean, I have It's just absolute, just curiosity. I mean, we are almost at the end of the program. So I thought I could just, take an advantage of both of you and, ask you this question. Anything, because it's a virus, I guess. Huh?
Yeah, I know. I don't have any concrete information, but then
Right, sir.
giving vitamin D could be, helping improving the immunity as one of the effects of vitamin D.
Right, sir. Thank you, sir. Sir, anything from you, sir? Dr. Chaddha, sir?
Thank you very much, ma'am. Thank you very much for inviting us. Thank you for listening to us so patiently, and thank you for respecting our views.
Thank you, sir. Thank you, Dr.
Sir.
Thank you, Ram, and thank you, the entire team of Pulse as well as the Ortho TV. Thank you very much.
Thank you, Kakatkar, sir. Thank you, Chaddha, sir. It was a wonderful session, sir. And of course, the questions and all were, made it all the more interesting. Thank you, sir, and good night.
Okay, good night.
Thank you.
Okay.
Thank you, sir.
If we are offline, Ram, I wanted to talk to you about